Parkinson's Empowerment Day at LV Physiotherapy. We're so glad that you can all join us. Thank you for coming. So my name is Lisa Miele. I'm the owner of LV Physiotherapy, and I'll be your MC for today. So this afternoon is all about learning, connection, and empowerment. We brought together some truly incredible speakers to share their expertise with you. And before we get started, I'll just do a few housekeeping notes. So the washrooms, as you probably already know, are on your right-hand side there, or there is one around the corner down the hall. Feel free to step out at any time if you need to. We'll be wrapping up around 4 o'clock. If we need to take a break at some point in the middle, we will. And we'll leave some time for Q&A with all of our panelists at the end, and probably after each of them speak as well. So we are very open to as many questions as you have. A lot of it will be based on question and answer style. We'll also be taking some event photos today, so if anybody, and we'll be sharing them on social media, so if anybody does not want themselves to be included in a photo or anything, just let one of us know, anyone with the logo on or any of the staff walking around, just let them know that you don't want to be included, and we'll make sure that you're not front and center on our photos. So before we move on, I'd like to extend a heartfelt thank you to Motion Specialties. So I don't know if you saw them on your way in. If not, make sure you stop by on your way out. They were gracious to sponsor our event today, which helped us to bring this free community event to all of you. So we're very grateful for their partnership. Like I said, you'll find their table out there. We encourage you to stop in and just to learn more about the mobility and home support equipment that they offer and how they're helping individuals living with Parkinson's throughout the Niagara region. The other thing I would like to highlight is an exciting community initiative that we are starting. So Maureen Thun, I don't know if anybody knows her, but she's going to be starting up the Parkinson's support group again in Niagara. She has run it in the past. She's going to be starting that back up again. So she is collecting email addresses at the front entrance there. There's a sign up if you would like to know more information about that support group. Please leave your contact information up there. She will be reaching out once she gets it all sorted. She's just finalizing the location. So that would be a great, kind of a wonderful opportunity to connect with others in the community and kind of continue the conversation beyond today's event. So today's theme is all about empowerment through education. We're beginning with someone whose lifelong work has helped shape how Parkinson's is understood and treated around the world. Dr. Irwin B. Montgomery, Jr. is an internationally recognized neurologist and neuroscientist specializing in movement disorders. He is Emeritus Professor of Neurology at McMaster University and has held faculty roles at the University of Alabama, University of Wisconsin, and the Cleveland Clinic. He has authored over 100 research articles and several leading books on deep brain stimulation, Parkinson's disease, and brain function. Today, Dr. Montgomery joins us for an open discussion, bringing decades of insight to help us better understand Parkinson's from both a scientific and human perspective. So please join me in welcoming Dr. Irwin Montgomery.
Good afternoon, everyone. It's an absolute pleasure to be here with you. And if you can't hear in the back, just wave at me and I will speak louder. And thank you very, very much for the invitation to come. It's a great joy. I've been involved with Parkinson's support groups for many, many years, and many of the people, the patients and their spouses and family and friends have helped me with my research over the years. So after about 50 years, I'm just beginning to pay back all the great things that the Parkinson patient community has given me. So this is payback to all of you. So as was mentioned, I've been doing research in Parkinson's disease, oh my gosh, for about 50 years now. Initially, my research was involved in training monkeys to play video games and then giving them a form of Parkinson's disease to see how things changed in the brain when they developed Parkinson's, and then developing techniques and methods to help with the diagnosis and the treatment of Parkinson's disease. I've been specializing in patients, in the clinical care of patients for, nearly 50 years as well. So I've seen a lot of Parkinson patients over my career. I've been involved in a lot of the drug trials and clinical trials that are now accepted medications for the treatment of Parkinson's disease. And I thought I would just share a couple of general thoughts with you But I think probably the best thing I can do is to answer your questions. And so after just a couple of comments, please feel free to ask some questions. I'd be happy to answer them. So one of the things that I've learned, it's truly remarkable. When I started out as a medical student, there were essentially 1.5 medications for the treatment of Parkinson's disease. We had levodopa, which was one of the first medicines, and before that we actually had another medication that went back to the 1800s, which was not so great, but it did help. Over the course of my career, the number of therapies has mushroomed. The number of different medications that we can use for the treatment of Parkinson's disease has expanded greatly. The number of therapeutic options in terms of physical therapy, occupational therapy, speech therapy that we can do for Parkinson's disease is just amazing. And now, most recently, the development of deep brain stimulation has brought hope to patients who have failed every other form of therapy. So just over the course of my career, sometimes I have to pinch myself to appreciate just how much we've learned, how much better we are at helping patients with Parkinson's disease. But there's bad news to that as well. And what that means is now we have so many different tools to deal with Parkinson's disease. It's become a complex disease to treat. Back when I started medical school, got Parkinson's disease, here you go, we'll see you in 6 months. Now we have so many different medications, so many different approaches that it really is quite complex. The other thing that I've learned over these many years is there are still a lot of misunderstandings about Parkinson's disease out there, and that's so unfortunate. We worked very hard over my career to correct many of them, but still they persist. And one other thing, if I had to say just a couple of things that I really want patients with Parkinson's disease and their family members and those that care for them to realize is that Parkinson's disease is eminently treatable. Eminently treatable. There are a great many things we can do. A patient should not just say, oh, that's it, I'm not going to get better, things are just going to get worse. That's not true. There's a myth that patients with Parkinson's disease stop responding to medication. That's not true in my experience. What does happen is the treatment gets more complicated. They start reacting to the medication in different ways. And so treating Parkinson's disease is always kind of a moving target. You're always having to readjust the medications. You're always trying to adjust your strategies because the patient is changing. One year they react one way to the medications. The next year they may react a different way. But that doesn't mean that they can't be treated. That doesn't mean that they can't be helped. So the first thing I would say is really expect to do better. Don't expect not to get better. Expect to get better. And if you're not getting better, keep upping the ante. Keep pushing harder and harder and harder until someone who has had a lot of experience, a lot of training says, this is as good as it gets. But don't stop short of that. So as I say, my 50 years in doing research in Parkinson's disease and caring for Parkinson's patients has made me very optimistic for the patients today and very optimistic for the patients that we'll be treating in the future. So at this point, I'd be happy to answer any questions. Now, I have to apologize, my hearing is very poor. Too much rock and roll music when I was growing up. My kids didn't believe that either. But it's not, being hard of hearing, it's not so much not hearing, it's that what you don't hear, your brain fills in. And I tell you, people say the strangest things. Okay? So to avoid that, I've asked Katie to help me out if there's a question that I can't hear. And if you ask your question and I give you an incredible, brilliant, erudite answer, but it's not the question that you asked, okay, just let me know and I'll get back to the question. So please, any questions at all? Yes, ma'am.
So any new information about stem cell research?
Stem cell research. Okay. Yes, that has been a very, very interesting issue. And because I can remember going way, way back some of the leaders in stem cell research, like Kurt Fried and others that I've worked with over the years. And unfortunately, on paper, it makes sense. It makes absolute sense. But in practice, it's been very difficult and very elusive, okay? So we know that in what we call idiopathic Parkinson's disease, which accounts for about 70% of the patients with Parkinson's disease, there's a loss of cells in the brain called dopamine neurons. And the idea is, well, people are losing their dopamine neurons, let's give them back. Okay, how can we give them back? Oh, well, where are we going to get these cells from? So it's now possible to take cells from a variety of sources and genetically modify them or modify them to produce dopamine. So let's put it back, okay? But when you think about it, the rationale kind of doesn't make sense. Like if your computer breaks down, you don't lift the lid up off the top of the computer and throw a bunch of transistors in there, right? And that's the problem that we've had. So much of the clinical trials show that a patient may benefit for 6 months, a year, and then they return back to the way they were, for the large majority of them. And it makes you wonder, is it really the cells that are making a difference for 6 months and something else is really there, like what we call a placebo effect? So it's very, very difficult. And then one of the other problems with this the cells that are put into the brain, they definitely make dopamine, but they do it in a very unregulated fashion. And you may see some patients who get too much, like levodopa, they have these writhing involuntary movements. Well, there were a lot of patients who had the stem cell, the brain cell transplant, who developed these writhing movements. And the problem was, if you have a patient who gets too much levodopa and having all these involuntary movements, you just stop the levodopa, that gets better. But when those dopamine cells are inside your brain, you can't stop them. And so there have been a number of patients who had what we call runaway dyskinesias from the fetal cell transplants, who required deep brain stimulation to bring that under control. So at this point, you know, we can still be hopeful. I think it's very important to continue to do the research. We are not nearly at a point where we can make this as a recommendation for patients. Now, to be sure, there are going to be patients who are going to undergo these sorts of transplants, and if that's the case, I urge them to do it in a research setting, so that whether it works or doesn't work, we'll still learn something. But at this point, I'm just not terribly optimistic that we're going to see major advances in the next few years. Yes?
And another question too, with the new deep brain stimulators that are working kind of in real time.
Right.
What are your feelings on that?
Right. So deep brain stimulation has been an incredible breakthrough. And so I've been involved in deep brain stimulation almost from the beginning of deep brain stimulation. And I started the deep brain stimulation program at the Cleveland Clinic in Cleveland, Ohio. And we were one of the first in the country to provide that. Interestingly enough, when I was learning about deep brain stimulation, I actually came to Canada to learn how to do it with Dr. Lozano in Toronto. So, and a great deal of my research over the last 20 years has been in with deep brain stimulation, trying to figure out how it works, okay? So the deep brain stimulation, it's amazing, because deep brain stimulation is really dumb. I mean, it just gives a pulse, 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 pulse. It's not very smart, but yet it has incredible benefits. Patients who have failed all sorts of other therapies can do dramatically well with deep brain stimulation. But it just keeps going. And so the idea is, well, maybe they don't need it all the time. Or maybe if we can focus the stimulation for just the time when the patient needs it and turn it off. And the problem is that really hasn't panned out. It really hasn't panned out. There have been a number of clinical trials with what we call on-demand deep brain stimulation. And they can produce benefit, but the benefits are really no different than with the old stimulators. And this is a very fundamental reason why. When I started getting involved in deep brain stimulation, oh my gosh, 30 years ago, 25 years ago, I said, we're going to figure out deep brain stimulation next week. We're going to figure it all out. We'll know exactly how deep brain stimulation works. We're going to know exactly how to make it better, right? 25 years later, I have no idea how deep brain stimulation works. No idea. I'm glad that it does, but I have no idea. And the reason why is because we have no idea what goes on in the brain of patients with Parkinson's disease. We have no idea how these neurons change their behaviors, change their firing patterns. And so I started out trying to understand how deep brain stimulation worked, but very, very quickly, I had to figure out how the brain works first. Okay? So based on that, we don't know from a scientific perspective whether the on-demand should be any better than the continuous DBS. There's no evidence that it's superior. But again, it's hard to rest on that because there's still so much we don't know about what happens in the brain when patients get Parkinson's disease. Yes, sir.
I had the DBS installed. Now, I have the Percept and Medtronic devices, but they have not turned on demand. Is it still in a trial here?
Right. Yeah, so so there are now a number of companies that have various types of deep brain stimulators, and they're the on-demand. What they try to do is they try to read the brain cell activity, and if they hear the wrong conversation, we're gonna turn on the stimulator. But one of the things about deep brain stimulation, it takes a lot of time after you start the deep brain stimulation to find exactly what are the right settings. And the programming can be very, very complicated in terms of adjusting the voltage and the frequencies. And the other thing that at the same time you're adjusting the stimulation, you're also adjusting the medications. So it usually takes about 3 months or so of adjusting the medicines and adjusting the stimulation to find out exactly what's the best balance for that. So one strategy is to do that first under continuous stimulation. And once you've settled on what kind of voltage, what kind of frequency, which electrodes to use, once you've settled on that, then trying to switch over to the on-demand. So that's one strategy.
Okay.
Sorry, did you have a follow-up on that?
I'll follow up later.
Okay.
I have a question. So when it comes to the DBS, is there certain criteria that you look for like the ideal patient to get DBS? Because I get a lot of questions on that. I'm like,
Yes.
who qualifies for that? And
Yes.
that sort of thing.
That's a very, very interesting question. And so, in all the various programs that I was involved in with deep brain stimulation, we would have patient conferences, and they would present the patient's case, and then we would decide, is this a patient a good candidate for deep brain stimulation? Because there are some risks involved in deep brain stimulation, and we wanted to make sure that it was a reasonable chance the patient could get better. And so we're always trying to find out what's the best patient for deep brain stimulation. Well, that's exactly the wrong question to ask. Okay, and I can remember when we first started doing deep brain stimulation at the Cleveland Clinic, we did a whole bunch of them very quickly because we had this huge backlog of patients. And then after a while, we did the backlog. We worked through the backlog, and they were complaining, well, we don't have perfect patients. I said, guys, we ran out of perfect patients 3 months ago. So really the question is not what's the perfect patient for deep brain stimulation. The question you have to ask, what is the least acceptable patient for deep brain stimulation? Okay. And if you take that approach, it changes your thinking dramatically. You're not looking for that golden patient that's going to do amazingly well, and you're going to be able to boost your reputation because that patient did very well. You want to look for the patient that has just the reasonable hope for getting better. So I encourage people not to talk about who's the best candidate for deep brain stimulation or any treatment. That's not the issue. The issue is who's the least acceptable. It changes the bar tremendously when you think that way.
So do you still subject the patients to those 3 or 4 days of tests or not? I had to go through 4 tests before
Before your stimulation, before your surgery, yes. Okay, so this topic of how to assess the patient before surgery is very complicated, very controversial. It's something among which honest people and scoundrels can disagree. So there are different approaches in different places. And so the key is, remember I mentioned that about 70% of Parkinson patients have what we call idiopathic Parkinson's disease. Well, that group does very well with a deep brain stimulation. The problem is there's about 20 to 30% that have a different kind of Parkinsonism, and they're not going to do so well. In fact, some of them can get worse with the deep brain stimulation. So when we're making a decision, one of the decisions that we're making then, does this patient really have what we call idiopathic Parkinson's disease, where we can be very confident they're going to get better? Or do they have one of these other kinds of syndromes then we can't be sure they're going to get it better? And one way to do that is we look at how they respond to their medication. So if a person gets better with levodopa, then you can be reasonably confident that they have idiopathic Parkinson's disease and therefore would be a good candidate. Okay? Well, in my own opinion, if you can get that based on the medical record, if you get that knowledge based on the medical record, and if you can get that knowledge based on your understanding of how the patient is doing, I don't know that you have to go through these formal testing of levodopa challenges. I think that that's misleading. And we have very, very good data that shows that about 8% or so of patients with idiopathic Parkinson's disease will not respond to levodopa. Okay, and so if you exclude